Recording in progress.
We are live, Dr. Ayush, you can proceed.
Okay, great. Hello and welcome to everybody to the third webinar of the Indian Academy of Neurology Young Neurologist Forum. At the outset, I'd like to thank all the presenters and the moderators who agreed and accepted to be a part of this webinar, this academic feast this Sunday afternoon. And I'd also like to welcome everybody who's joining us live on YouTube as well as on Zoom. So without further ado, let's get this rolling. And for that, I'd like to hand it over to Dr. Vivek to start with his first case.
Yes, sir. Thank you so much. I'll be just sharing my screen. Is my screen visible, sir?
Yeah.
Yes.
Good morning, everybody, senior faculty. I'm Dr. Vivek. I'm a final year senior resident at NIMHANS. So today I'll be presenting this case of cerebellar ataxia and chorea with supranuclear gaze palsy in a young female. It's an unsolved problem so far. So going into the case details. So a 25-year-old lady with no known comorbidities. She presented with tremors of the left upper limb of 10 months duration, followed by right upper limb of 8 months duration. Thereafter, she developed imbalance while walking of 7 months duration, speech disturbances from the same time, and she had involuntary movements of the limbs of 1.5 months duration before presenting to us. So it started with the left upper limb tremors, followed by right upper limb tremors after 2 months. So she used to have tremors while reaching for the objects and while holding the objects. However, there were no tremors at rest, and there was incoordination of hands and past pointing while reaching for the objects. And later she developed imbalance while walking after about 3 months after the onset of tremors, in the form that she was swaying to either side intermittently. She was requiring the support of the walls, which gradually worsened such that she was requiring at least one person support to walk. At the same time, she also noticed her speech disturbances by the family members, where her pronunciation of words, family members were not able to understand clearly. There was decreased clarity in the pronunciation of the words, and the gap between the syllables which she spoke was increased. And 9 months after the onset of tremors, which is the last symptom, is the involuntary movements of the limbs and the body, which were purposeless, dance-like movements of the arms and legs, which are partially suppressible and they do not occur in sleep. So all these symptoms worsened before 1.5 months before the presentation, in the form that her imbalance worsened so that she was not able to sit even with one person support. There was limb incoordination, speech, and coriform movements of the body. And she was requiring assistance for all her activities of daily living. However, there was no history of any visual difficulty, double vision, swallowing difficulty, no history of any ball bladder complaints, no history of any behavioral or memory disturbances, no history of any stiffness of the limbs, and there were no seizures, myoclonus, or abnormal posturing of the limbs and any startle response. However, she had bilateral knee joint pains from last 1 year, for which no medical consultation was taken. And these knee joint pains were not associated with any early morning stiffness. There was no history of any other systemic symptoms such as orogenital ulcers, rashes, Zika symptoms, weight loss, or fever. There was no history of any jaundice, no recurrent sinopulmonary infections, recurrent diarrhea, or steatorrhea. So currently, she is wheelchair bound, requires support to sit in bed, requires support of at least one person to stand and walk. No past significant history. She was born out of non-consanguineous marriage, no similar history in any other family members. So summarize an analysis of the symptoms, may I request Dr. Rohan, sir?
Next slide. So patient, here is a young lady who presented with 1 year history of tremors, which was suggestive of intention tremors, incoordination, limb incoordination, gait ataxia, and dysarthria. So I would like to localize these all symptoms to cerebellum and its connections. And 9 months after the onset of the symptoms, she developed chorea, of the generalized chorea. So I will localize to a bilateral caudate, basal ganglia, and its connections.
So initially, she had presented to us 2 months after the onset of this illness. So initially, she had only had tremors and mild ataxia. So at that point of time, we used the following approach for cerebellar ataxia. We either considered as a genetic or an acquired cause. So to summarize, yes, sir.
Yeah, Vic, if I can just interrupt here, I think we should be flowing. Tremor, we are very clear that it was only intention tremor, or was it rest tremor at that time also, rest or postural tremor?
No, sir. It was just intentional tremor.
So it's very clearly only intentional cerebellar tremor.
Yes.
Fine, we can go ahead. So till now we have only cerebellar syndrome.
Yes. So based upon the history, to summarize, it is early onset progressive pancerebellar ataxia with no family history, with age of onset around 24 years. So if we see the causes of ataxia, acute, subacute, and chronic ataxias, at that point of time, it is acute to subacute ataxias. So we considered the autoimmune disorders, infections, and structural causes as the main etiologies. And other deficiencies and autoimmune disorders such as multiple sclerosis also have been considered. In the genetic causes, we considered Friedreich's ataxia is one of the possibility, and spinocerebellar ataxia is one of the possibility. So later on, she had these involuntary movements which are suggestive of coriform movements of limbs and the body. So we have gone through the causes of chorea, primary, secondary, and other. So chorea with ataxia, the following diseases we came across, like Huntington's disease, but it occurs only in the later disease and the onset is not matching. Others are DRPLA, neuroacanthocytosis. And we also considered inborn errors of metabolism which can cause chorea. And we have evaluated for the following. So the common causes which we considered ataxia with chorea, probable genetic etiology. One is the most common is the Wilson's disease, followed by which ataxia telangiectasia and other NBIA spectrum disorders, spinocerebellar ataxias have been considered. So in our case, the following possibilities are like in the genetic etiologies, Wilson's disease, NBIA spectrum disorder, DRPLA, neuroacanthocytosis, Lee syndrome, mitochondrial such as Golgi mutation, and some organic acidemias along with spinocerebellar ataxia. In acquired causes, we considered mainly the autoimmune etiology, which includes systemic vasculitis, autoimmune encephalitis, paraneoplastic etiology, and infectious such as, although rare, but we also consider the possibility of syphilis, Whipple's disease as a cause of ataxia with generalized chorea in our case. So going on to the clinical examination, patient was conscious oriented. On general physical examination, there is no cataract, no KF ring. On systemic examination, there is no organomegaly. Her higher mental functions, her MMSE is 30/30. However, her speech has a scanning quality. Her visual acuity is 6/6. Fundus examination is normal. But however, on an extraocular movement examination, she had vertical supranuclear gaze palsy Saccades are slow with pursuits impaired. And on motor examination, she had hypotonia. There is no bradykinesia. She was moving all her limbs against resistance. However, exact power of the muscle could not be assessed because of severe incoordination and these coriform movements. And she continuously had these dance-like movements of the limbs and the body, which did not occur in sleep. Her sensory examination was normal. There were no pyramidal signs. And cerebellar, she was having severe truncal ataxia requiring 1% support to sit. And her finger-nose-finger incoordination was impaired. There is dysdiadochokinesia. The gait, which we'll be seeing in the next videos, she was swaying to either side, requiring 1% support to walk. It is suggestive of choric along with ataxic gait. And there was also finger dystonia noted.
Before you go for the video,
Yes, sir.
can I just discuss in 1 or 2 lines?
Sure.
So we have a young patient who has progressive cerebellar syndrome followed by chorea, right? And I just wanted to reconfirm that how long is the history?
10 months, sir.
Only 10 months, right? So once you see the progression, once you see the symmetry, looks like structural cause or MS is less likely because it's not acute onset, it progressed, right? So we have to think of autoimmune fine, but we have to think of degenerative also, what we are thinking right now. Now, you added one very important thing is vertical supranuclear gaze palsy. Once you add this, the DD becomes very, very narrow, right? So before going for a video, would you like to think of some condition, or after video we'll talk about that? Yeah, we have to keep that supranuclear gaze palsy in mind. So not repeating all the big list.
Can I show the video?
Can I show the video, sir? Is it okay?
Yes, fine.
Yes.
Just to drag it.
If you just press spacebar, it might play.
Another way is to stop screen sharing and restart again.
Just click on the video. Not that.
You can click on the play.
Play.
Cursor is just
to the right. Click on the play bar.
Click on the bar right next to play.
Dr. Vivek, you can just click on the play button. Is that not playing your video?
No, I'm pressing it. It's not playing.
Okay, you can go back to a previous slide. From here only, you can just go back from the left arrow. Yeah, go back to the previous slide.
It's not stuck.
Okay, you can use your keyboard. Can you try using your keyboard using the left arrow?
Still, it is not coming, ma'am.
Okay, then you can escape your full screen mode. Just one moment. I'll stop your screen share. You can escape your full screen mode and share your screen again.
Okay.
In the meantime, I'll just put forth a few questions that have been asked by the audience. One is, why is SCA 17 not considered? And people seem to like to put their money on Whipple's disease as well as Niemann-Pick C as of now.
Yeah. I guess SC17 was there in the list.
Dr. Rohan, would you like to take that question from the audience? That was SCA 17 considered on the basis of history and examination? That's been
Not
asked.
considered. Usually, SCAR 17 has a later age of onset with predominant dementia, psychosis, psychiatric symptoms, chorea. So, since it was 1 year duration, it was not first in the list. But
Okay.
it's one of the differential diagnoses, but not in the first list.
Right. And Dr. Mukunda Burma has asked that was SCA 2 and SCA 7 also considered? Dr. Rohan?
Yeah, those are all in the later in the list, but it's not the first cause.
Okay, sure. So, Mansi, can you help share the screen from your end if possible, and we can play the video?
Yeah, I don't mind if you can send me the PowerPoint.
Just give me 1 minute, ma'am. I think it is almost sorted.
Okay, all right.
Rohan, if you don't know the case, if case is not yours, what will you think as first? Or you'll biased?
So I will think first as Wilson's disease.
Wilson's disease, because yeah, chorea and Wilson's disease can be seen in 6 to 8% cases. From chorea, it's rare, but yeah, it can be seen. Yeah.
Only later age of onset. Not considered.
Can I just make a comment?
Sir.
Yes, sir.
Yeah, so it's only a 10 months history. So I think that, by and large, I've seen this tendency amongst the, students also, and also among the young neurologists, that they consider degenerative as a first choice, but that should not be. You should always think of a correctable, treatable entity. So just a 10 months history. And so therefore, I think you should first explore the correctable ones. That's my comment.
Is the video visible, sir, on the screen?
Yeah.
Yes, it is.
So I'll just play the video. So we're trying to check the extraocular movements, which are very slow, and there is supranuclear like upward gaze restriction was there. And a continuous, as we can see, continuous movements of the limbs, and she has severe truncal ataxia. Most of the examination is being interrupted by this involuntary coriform movements.
There is finger dystonia, also dystonia. Can you comment on the gait?
Yes. Like, there was severe ataxia. She was requiring 1% support, and also
It's not wide based. Most likely choric gait.
yes. So after the examination, like
Organomegaly?
there was no organomegaly, sir. In the examination, I already mentioned there is no organomegaly, hepatosplenomegaly.
We should give 1 minute time for discussion of the video.
Sure,
So,
sure.
in the video, it's very clear the patient has diffuse generalized chorea, very profound, affecting her all activities. You showed that patient has supranuclear gaze palsy, perfect. You have seen that. To demonstrate that, we should we could have done this head movement to see the real movement is there, which I could not see there, but I take your point. Therefore, student, to say supranuclear gaze palsy should be there. And when we fix the hand, the eye should move. So only then we can say supranuclear gaze palsy. From the video, I still have to convince myself right now that patient had profound ataxia. Maybe chorea is so much that ataxia is masked, because right now when she is standing, imbalance is there. But I don't see a proper ataxic gait at this point in time. Maybe early on the patient has finger nose positive, intention tremor, speech may give some way, but for this video, I will say this is generalized chorea, agree, with some dystonic posturing. At point, I could see some dystonic posturing. Ataxia historically is there, but difficult to say with this video. So this is my comment regarding video, and then we can move on.
Sure, sure, sir. So out of these possibilities after the clinical examination, we mainly considered ataxia with severe generalized chorea along with supranuclear gaze palsy. First possibility was always Wilson's disease, as well as then other treatable causes, mainly the inflammatory causes, which we considered like autoimmune causes like Behçet's disease, and infectious causes like Whipple's disease.
Patient had joint pain.
Yes,
so that is one pointer maybe for discussion because of treatability.
Yes, sir, correct. So other differential are also since ataxia with supranuclear gaze palsy, Niemann-Pick's type C was also considered among the differentials, along with the other spinocerebellar ataxias. So I'll just go through the investigations which we did for this patient. Routine investigations including CBC, LFT, RFT, serum electrolytes, thyroid function tests, lactate, ammonia were normal. ANA profile, ANCA, ESR, CRP, CPK were normal. HIV was negative. Serum VDRL was negative. Serum copper studies was slightly elevated. It is 237 micrograms per deciliter. But serum ceruloplasmin and 24-hour urinary copper levels were normal. And ophthalmological evaluation for KF ring was negative. Other autoimmune workup, including autoimmune antibodies and paraneoplastic antibody panel, was negative. Peripheral smear for acanthocytes was negative. We did a CSF analysis for 2 cells, which included 2 lymphocytes with normal protein and glucose levels. CSF OCBs, serum and CSF NMO MOG were negative. Ultrasound abdomen and pelvis did not show any organomegaly. And EEG was also normal. So I'll just go through the imaging findings. The T2 weighted images, which is showing hyperintense signal changes involving the brainstem, as well as the capsuloganglionic region external capsule, as we can see here. Basal ganglia region and the centrum semioval region, bilateral hyperintensities are there. This is a sagittal section of the same T2 weighted imaging. It's showing signal changes involving the brain extending into the pons. The flare images showing the same hyperintense signal changes in the same areas. The T1 imaging, which is showing hypointensities in the corresponding same areas. There is a minute punctate contrast enhancement. If you see, if my pointer is visible, the periventricular regions. So to summarize the imaging findings, there was relatively symmetric T2 prolongation and facilitated efficiency in bilateral external capsule, capsuloganglionic region along which is extending into the posterior limb of internal capsule and corticospinal tract, involving the midbrain with no suggestion of any red nucleus pairing. These changes are also seen in the bilateral medial temporal lobes and in the bilateral central semioval region with the minimal contrast enhancement. And there is also dense mineralization of the bilateral substantia nigra, red nuclei, and globus pallidus. And there is no ventriculomegaly, and bilateral optic nerves and chiasma are normal, with normal signal intensities. So after considering the neuroimaging, main differentials became even less. One is Behçet's disease because brainstem and posterior fossa involvement was predominant, along with Whipple's disease because similar hyperintense signal changes were reported in CNS Whipple's disease, and other is Wilson's disease. So we evaluated for the. Can I go ahead, sir?
We can just give a break here, and I'll ask Ayush that can we go to the questions, whether till now we have satisfied all the questions so that they feel involved.
Sir, definitely. Thank you.
Yes.
A few questions that have been asked is that one has been asked by Dr. Meera, who's asking, was there any possibility of a mitochondrial disorder in this presentation?
Yes, yes. Like mitochondrial was also considered as a differential because there was multi-axial involvement, as we felt, and that is the reason.
Keep on going quickly.
Yeah. One is whether Huntington's disease was considered, and whether vestibulo-ocular reflex was done, and whether Iglon-5 was considered in view of chorea and gaze palsy, and finally treatable disorders like APLA and Hashimoto's encephalitis, apart from the ones that you mentioned.
Perfect.
Huntington disease was not one of our main differentials because it started with ataxia, and the age of onset means the ataxia usually occurs later in the disease in Huntington's, and mitochondrial was considered because there was multi-axial involvement. That is the reason we did serum ammonia lactate, fasting serum ammonia lactate, which were normal. As you can see in our differentials, we considered Paul G is one of the Leigh syndrome and Paul G as one of the differentials. And Iglon-5, because there was no predominant sleep-related issues for the patient, we did not consider them in the
age of onset.
Age of onset as well is odd for Iglon-5, and there were no sleep-related issues in the patient. We did not consider Iglon-5, even though it is a treatable cause, as we all know. But the clinical presentation-wise, we did not consider Iglon-5.
Before we quickly move forward, one more question. Should we consider seronegative autoimmune encephalitis, especially considering the MRI picture that was seen?
It is one of the possibilities.
Okay.
Supranuclear gaze pulse is unusual.
CSF was negative. CSF was completely normal.
And EEG was normal.
Yeah. And patient did not have proper encephalopathy, basically. EEG was normal, you're right. So we'll move on. Dr. Devashish's point is well taken here that in 10 months history, we should stress more upon treatable, and that's how we're looking into it. Secondary causes. Good. Yes.
So can I go ahead, sir?
I think so, yes.
So after the taking the neuroimaging into also a picture, we evaluated for the possibility of Behçet's, which included HLA-B51 testing. Pathology test was negative. Both HLA-B51 and pathology were negative. So the duodenal biopsy was done along with upper GI endoscopy. Duodenal biopsy was done, which was normal. There was no findings suggestive of Whipple's disease. There were no PAS positive macrophages found. However, CSF PCR for Trephorema Whippleyi, which we could not do. We tried so much, but because of non-availability, we could not do the test. And clinical exome sequencing, considering the genetic etiologies like Wilson's, was done, which is negative. So, considering a possibility, like we consider the possibility of treatable immune-mediated disease, and we given a trial of IV methylprednisolone along with large volume plasma exchange. As someone asked whether there was a possibility of seronegative autoimmune encephalitis. So we considered an immune-mediated etiology, after which we decided to give an IVMP trial as well as large volume plasma exchange. Surprisingly, patient had improvement after IVMP and large volume plasma exchange, and she was able to walk with minimal support. She was able to sit independently, and there was mild improvement in coriform movements also. So we just studied the literature regarding the imaging in CNS Whipple's disease, as 1 or 2 cases have been described, reported from Niemann also previously with similar imaging findings. Diffuse unilateral or bilateral abnormal T2 hyperintense signal changes in the mesial temporal lobe, midbrain, hypothalamus, and thalamus with transient contrast enhancement are the possibilities in the CNS Whipple's disease. Even though isolated CNS Whipple's disease is rare, and duodenal biopsy can be normal in CNS Whipple's disease, So that along with the immune-mediated etiology, Whipple's disease is the second most differential we kept in mind, and we have given the patient. We treated her and discharged her on cotrimoxazole also. So our impression regarding the case was immune-mediated CNS illness, which is versus isolated CNS Whipple's disease. So, any comments, sir?
Oh, amazing case, amazing, and that's beauty of it, because this is turning out to be treatable. Not clearly, we don't have diagnosis yet, but right from the beginning, it was giving flavor of inflammatory infective, 10 months, almost really rapid progression. And this MRI is giving some evidence that this can be Whipple's. So you rightly treated as Whipple's or autoimmune encephalitis, seronegative. So this is the group it belongs to. It doesn't belong to any genetic condition. Since you have ruled out NPC can present like this. Niemann-Pick type C exactly like present like this, chorea and vertical gaze palsy. At this age, it can present, but it's too rapid for that, and you have done the sequencing. But we have to keep in mind sequencing sometimes misses NPC because of intronic involvement, so it can miss. But NPC, Niemann-Pick type C, is less likely in this case, seeing the clinical presentation. Now, one quick parting shot, that suppose MRI would have been normal or only slight hyperintensity, not giving so much of clue, would you have treated with steroid and IVIG?
Yes, sir.
Yes. So we do treat quite often with immunotherapy, even if you don't have clear evidence, because that's treatable. And one quick last question from my side, then you can take over. Whether you'll repeat IVIG after a few months' time, because patient has improved, but not improved completely, right? So whether you will repeat IVIG again.
Yes, sir. We are considering the financial issues. We are planning to for repeat immunomodulation therapy, either in the form of large volume plasma exchange, again repeat, as well as pulse IVMP. IVIG is also in our consideration, but here financial constraint also matters in the treatment. But definitely, sir, yes.
I understand, and sometimes repeat biopsy itself may yield a positive again. So we are chasing some diagnosis we don't have yet, but treatable we are chasing. And thank you very much, Vivek. Rohan, all yours, and then Ayush can take over.
Thank you, sir. After the presentation, we thought of immune-mediated CNS illness versus isolated CNS Whipple's disease. So both are the possibilities. So as Vivek told, Whipple's disease neurological involvement is isolated. Neurological involvement is rare without systemic symptoms, but it can occur in 5% of patients. They may not have systemic symptoms like weight loss or recurrent or joint pains, and they usually involve the gray and the white matter junction. Involvement is more common in Whipple's disease. The pathogenesis is not understood till now, and it is a very rare disease. So we treated for both Whipple's as well as the immune-mediated conditions.
Great case, Vivek. Thank you very much. And
just one comment, Rishikesh. I think it would have been better that if you could put up the diagnostic criteria for neuro Whipple's, for the residents. So that would have actually been, they would remember it, because in the context of the case.
Agree, sir. For everybody, for us also.
Yeah,
agree, sir.
Yeah.
And imaging, the comment is that imaging afterwards might help. And oral steroid, somebody asked that oral steroid can be given or not.
Yes, oral steroids were given.
All right. Thank you very much. Ayush, all yours. And we try to finish in 30 minutes time.
No, sir. Thank you so much for joining. Thank you, Dr. Vivek, Dr. Rohan, for the great case. I'm sure everybody learned quite a lot. And thank you, Dr. Debashish, for your comments. And we'll ensure that from the next meeting onwards, whatever the eventual diagnosis, we'll have a diagnostic criteria. Now going from movement disorders to the stroke subsection, Dr. Rishikesh should be taking our leave. He's in a meeting. He very kindly agreed to join.
Thank you. Take care. Bye-bye.
We'll be going to hypertension with recurrent focal neurological deficits. That will be presented by Dr. Archana and moderated by Dr. Vishnu. And unfortunately, Professor Shailaja could not join us today because of a sudden meeting that came up on her part. So over to Dr. Archana.
Thank you so much, sir. Is my screen visible?
Yes.
Good morning to all, and thank you, sir, for providing me this opportunity. So I'll be presenting this case of hypertension with recurrent neurological deficits. First, coming to the clinical scenario, he's a 42-year-old gentleman, businessman by occupation, had a 27 years history of multiple complaints. He was born out of a non-consanguineous marriage. He developed his first event at the age of 15 years, where he developed an ulcerated skin lesion on the medial right thigh, along with the right foot drop. With the presumptive diagnosis of tuberculosis, he was started on anti-tubercular drugs along with the steroids. The skin ulcer recovered within 1 to 2 weeks, and the right foot drop also recovered within 6 to 8 weeks. However, the patient stopped the ATT after 1 month. He had another event at the age of 24 years. He developed left foot drop at this time. It also improved with corticosteroids in 3 to 4 weeks. However, on the steroid withdrawal, he developed fever, left foot ulceration, abdominal pain. This time, the left foot ulcer biopsy was done and it was suggestive of SLE-like. So the corticosteroids were given for a prolonged period for approximately 4 to 6 months, and the symptoms resolved on that. At this time, he was also diagnosed with hypertension and was treated for the same. At the age of 30 years, he developed the third event. He developed left foot drop and left foot ulcer at this time. He went to a rheumatologist and he was prescribed monthly cyclophosphamide injections for 6 months. With these injections, the symptoms again show resolution, but after that, he was lost to follow-up for approximately 6 years. At the age of 36, he again developed event 4, in which he had fever, abdominal pain, and testicular pain, skin ulcerations in both the lower limbs. At this point, HIV, Hep B, C, and Hep C were negative. CT iodogram was normal, and he responded well to pulsed corticosteroids and mycophenolate mofetil. However, he was continuously having those recurrent relapses of fever and abdominal pain and skin lesions every 1 to 2 years, and he was tried on a combination of multiple immunosuppressants in the form of mycophenolate mofetil, azathioprine, and cyclophosphamide. But again, he had a devastating event that at the age of 40 years, that was a major event 5. He developed fever, abdominal pain, left foot drop, and an unintentional weight loss of 22 kg over 2 months. This time, the CT abdomen showed left perirenal hematoma, splenic and bilateral renal cortical infarcts. CT aortangiogram showed multiple aneurysms in the medium-sized abdominal aortic visceral branches. Chest X-ray and 2D echo were unremarkable. Upper GI endoscopy was suggestive of esophageal candidiasis, and colonoscopy showed multiple linear ulcers throughout the colon, and the biopsy of these ulcers showed CMV colitis. This point of time, he was managed conservatively with intravenous immunoglobulins along with antivirals and antifungals. In the later part, he will receive 4 rituximab infusions, but his foot drop persisted, and the nerve conduction study showed axonal pattern of sensory motor involvement in the lower limbs, left more than right. Then again, at the age of 42 years, he developed event 6, that he developed 2 months history of subacute onset, moderate intensity holocranial headache, along with sudden onset left hemiparesis and left-sided focal seizures. On examination, he had alopecia, multiple healed ulcerations were found below the knee, he had livedo reticularis in the distal feet, there was no organomegaly, and also he had left-sided hemiparesis and left appendicular cerebellar signs. So to summarize, he's a young hypertensive, symptomatic for past 2 decades with multi-system involvement in the form that CNS and PNS involvement was there, GI system was involved, integumentary system was involved, and gonadal involvement was also there. Every time he was having constitutional symptoms as well, and all these symptoms, he showed partial response to steroids and other immunosuppressive therapies. In the prior investigation, the CT aortogram was showing aneurysms and it depicted that it was there was involvement of the small, medium, and large vessel involvement. So what are the most likely differential diagnoses till now? So at this point, in view of the systemic features, along with the constitutional syndrome, along with the fever, partially responding to steroids, and suggestions showing that there was a pans vasculitis involvement, the first DT that will come to our mind will be a systemic vasculitis like PAN, SLE, antiphospholipid antibody syndrome, rheumatoid arthritis, or some toxin induced. Another DD would be ANCA-associated vasculitis like GPA or MPA. Another could be sarcoidosis, porphyria, cryoglobulinic vasculitis, or Fabry's disease. So we worked on the basis of these differential diagnoses and we further investigated the patient. So on further investigations, again his HIV, Hep B and Hep C were negative. Inflammatory markers, that is ESR and CRP, were elevated. ENA, ANCA profile, and ACE concentrations were all found to be normal. His urine examination showed no cells or proteinuria and was negative for porphobilinogens, and it was tested thrice. He was a non-smoker and there was no history of any illicit drug use or other medications. His urine and serum toxicology screen was also negative. So this was his MRI, which actually showed multiple infarcts in bilateral multiple vascular territories. We can show this is the DWI imaging showing the multiple cortical infarcts both in the deep matter as well as in the cortical matter. So to further probe, a DSA was done. As we know, the DSA, it is actually showing focal narrowing as depicted by the arrows in both the MCA as well as the ACA branches in both A and B, and in C it is showing the focal narrowing in the posterior cerebral arteries as well. So we further probed and we did a skin biopsy. The skin biopsy and on the HNA stain, this is A part which is actually showing the epidermis, which was completely normal. The B and the C part are showing the epidermis. The dermis, and here we can clearly show there is a mild chronic perivascular infiltrate along with the concentric thickening of the vessels. So are our differential diagnosis same till now? I think we have narrowed down all our differential diagnoses to either a childhood associated PAN or any other systemic vasculitis or any monogenic vasculitis. So we further probed and we sent for the genetic analysis. So this was the clinical exome sequencing report that showed a homozygous likely pathogenic variant in the ADTOA gene, in which there was a mutation in the 13GC. So how to differentiate between these adult PAN, childhood PAN, and deficiency of adenosine deaminase 2, that is the DADA2. The adult PAN, the childhood PAN, and the DADA PAN. The DADA, all the three, they actually show arteriographic abnormalities, mainly PAN shows involving the both on system medium, small, and large vessel vasculitis, or there should be a biopsy which is showing a necrotizing vasculitis in medium or the small arteries. The adult PAN and the childhood PAN usually have these abnormalities, but the DADA2, they have three phenotypes. One is the vasculitic phenotype. The second one is the bone marrow dysfunction or the hematologic phenotype. And the third one is the immunodeficiency phenotype. However, the skin involvement, the hypertension, the peripheral neuropathy, the renal involvement are all the same features. But the most important feature is the CNS involvement in the form of hemorrhagic or ischemic strokes. It occurs in approximately 50% of the DADA patients. And in childhood PAN and the adult PAN, the incidence rate of these strokes is quite less common. We managed this patient by giving intravenous pulsed corticosteroids along with subcutaneous adalimumab in March 2020 during the COVID pandemic. After 1 month, he developed acute abdomen episode, had an intestinal perforation, was operated out elsewhere. However, he could not survive and died a few days later. So the learning point of this case is when there should be a high index of suspicion for deficiency of ADA2. In childhood PAN, in familial PAN, when PAN is not associated with Hep B infection, specifically when the patient is showing atypical immunodeficiency features with autoimmunity plus or minus lymphoproliferation. Whenever we have early onset strokes associated with systemic inflammation as well, or when there is an unusual disease course in the form of clinical manifestations or treatment response to the conventional therapies. So I'll be talking a little bit about the DADA. It was the first syndrome that was described in 2014, two groups had actually independently described this novel syndrome of systemic inflammation and vasculitis, which is caused by a mutation in the ADA2 gene. It was earlier known as the CECR1 gene. Up till now, 300 cases have been published in the literature, and the disease prevalence is approximately 1 in 2 lakhs. When we talk about the genetics of this disease, this is an autosomally recessively inherited monogenic disease. And in this, both biallelic homogenic mutations can be found, and around 50% of the patients, they present with compound heterozygous pathogenic variants. Any kind of a mutation can be possible in the exons. However, in the vasculitis phenotype, the most common mutation are the missense mutations, and the loss of function variants are mainly found in the hematologic phenotype with bone marrow failure and the immunodeficiency phenotype as well. The most common pathogenic variant in Turkey, Israel, and South Asia is G47R, and in Europeans, it is R169Q. So let's talk a little bit about the pathophysiology of DADA2. What happens is ADA2 is actually produced by the myeloid cells, and this ADA2, it deaminates adenosine to deoxyadenosine. When there is deficiency of this ADA2 gene or reduced enzymatic activity of this ADA2, there is increased adenosine extracellularly, which causes decrease in the mature B cells. It alters the endothelial cell integrity. There is a dysregulation of the NETosis, that is the neutrophilic extracellular trap formation. There is a chronic neutrophilic activation. There is increased pro-inflammatory M1 macrophages. And these three things, they combine to leads to increased TNF alpha inhibitors, interferons, and a little bit of interleukins in the form of interleukin 6, 8, and 10. So as I have already mentioned, DADA2 has 3 phenotypes, and these are the pleiotropic manifestations of DADA2. The most common one is the vasculopathy and the inflammation, and it can involve any system, any part of the body in the form of constitutional symptoms, GI system, cardiopulmonary system, integumentary system, nervous system, musculoskeletal system, or renal system. In immunodeficiency, there can be low immunoglobulins as well as a reduced B cell. In the bone marrow failure, there can be variable cytopenias along with the pure red cell aplasias. When we talk about diagnosis and screening for DADA2, it can be done in 2 ways. The first one is we can measure the ADA2 activity level by doing the spectrophotometric assays. Another one is the genetic testing. We can go either with the targeted next generation sequencing, that is the Sanger sequencing, or the whole exome sequencing. Both of them can actually detect any kind of a mutation that has been present in the DADA2. When we talk about the treatment is usually phenotype based. In the vasculitis and systemic inflammation, TNF alpha inhibitors are being given, and clinical improvement has been reported with the use of etanercept, adalimumab, infliximab, and golimumab. The evidence for these TNF alpha inhibitors come from 2 case series. This was the first case series that was a UK-based case cohort. It was a retrospective analysis of 27 patients who have actually received anti-TNF treatment for a median of 32 months. In this picture, we can clearly show that the clinical event rate was measured in the form of CNS ischemic event rate or non-CNS ischemic event rate. In both the things, the event rate was decreased after the TNF alpha treatment. And the median rate for ischemic events per 1,000 patients was before the TNF initiation, it was 2.37. And after the anti-TNF initiation, it was 0%. So it was clinically very much significant. The another evidence, it comes from another study, another cohort. It was a prospective cohort that came from the US, and it was published in 2019. In this case series of US, 15 patients of DADA2 had a history of strokes, and they were begin on the TNF inhibitor therapy. These 4 TNF inhibitors were given, and it was found that in the before TNF, anti-TNF initiation, the recurrence rate, the number of cumulative incidents of strokes were 55. And after anti-TNF initiation, the cumulative incidence of stroke was absolutely 0. So in a binomial distribution and for a matched follow-up for the patient months, it was concluded that 37 strokes were there in the cumulative incidence rate before the start of anti-TNF therapy, and it was again 0. So it was very clinically significant, and the p-value was less than 0.001 in this study as well. When we talk about the treatment of asymptomatic or no vasculitis, treatment with TNF inhibitors still remains a difficult dilemma, whether we have to go for that or we don't have to go for that. For the symptomatic carriers, optimal management of heterozygous ADA2 deficiency is again quite uncertain due to the lack of the systematic study. But in bone marrow failure and immunodeficiency, hematopoietic stem cell transplantation has proven an effective role. So this was a literature review that was published in 2022. It actually evaluated the treatment of DADA2 and explored the factors which were associated with the disease outcome. Approximately since 2014 till December 2020, all the patients of DADA2 that were genetically or enzymatically proven, they were taken into account along with the treatment outcome and their results. In this study, in this literature review, it was found that vasculitic manifestations or the vasculitic phenotype was very predominant and was approximately present in 95.6% out of the total 225%. Among the vasculitic manifestations, neurologic involvement and cerebrovascular events were also found to be significantly high. Then the
Archana,
next...
Sorry to butt in, just finish in 2 minutes so that we can have 10 minutes of discussion.
Okay, sir. This is the last slide, sir. So the hematologic abnormalities were found in approximately 135 patients, and immunodeficiency was found in the lowest group in approximately 47.6%. So when the factors which were associated with a good response to TNF alpha therapy were also analyzed, and it was analyzed in subgroup 1 and 2. Subgroup 1 included all the patients who had received TNF alpha. Subgroup 2 included patients who had excluded the patient who had received TNF alpha along with corticosteroids. In both these subgroups, it was found that the patients with a higher acute phase reactants and the hematological abnormalities showed good response to TNF alpha inhibitor therapy. Apart from the corticosteroids and TNF alpha inhibitor therapy, these were the other therapies that were also being used. However, none of them were proven to be much effective. So till now, hematopoietic stem cell transplantation and TNF inhibitors are the proven therapies for that. So the key points that need to be taken home are the deficiency of ADA2 syndrome should be considered in young people with fever, rashes, and stroke, and in all cases where we are suspecting the childhood PAN. And anti-TNF factor agents are the treatment of choice for DADA2. Thank you. Any questions, sir?
Thank you, Archana. Can you hear me?
Yes, sir.
Okay, so it's an interesting case. So in this case, I think the DADA2 was, I mean, even the gene for DADA2 also was discovered only in 2014. So he was symptomatic for last, I think, or more than 20 years. So he was initially 15, almost close to 15, 20 years. So he was initially treated as PAN. So the current concept is that anyone, I mean, even this series, most of the series says that even 1/4, probably 50% of all childhood PAN may actually be DADA2. That's one thing. Did you come across any Indian series while making the review of literature?
Yes, sir. There was one Indian series that was given by Sharma et al., in which 13 patients were included. And out of them, neurological manifestations were present in approximately...
Not 13. I think they had much more. I think they have 30 or so, more than 30 cases. I think they had. So that was, I mean, that was the, I think, largest series from India was from them, from the PGA group, which had the rheumatology group from PGA. They had around close to 33 cases, I think they had. And it was a collection of, it's a retrospective series from multiple rheumatologists across India were recruiting. They also had predominantly had a neurological manifestation. So I think at AIIMS, we have 3 cases. So most of them had, so all of these centers have a referral bias will be there. If neurologists who are seeing DADA2 are more likely to see more of neurological manifestations, rheumatologists are more likely to see more. So I mean, the so-called description of features, this case series, which with the proportion of symptoms developing, they may be skewed towards the specialty which they are treating. That is also there. And DADA2 is a great mimicker because it almost every system in the body can be involved, from the skin to GI to nervous system, central and peripheral nervous system. So almost every system is involved. The important point to note is the TNF alpha inhibitor. So even the if you look at the Indian series also, there was considerable, I think those who were treated with etanercept, I think a couple of patients had a disseminated TB and they died also. So, I mean, TNF alpha inhibitor is not, I mean, it's not very innocuous treatment for at least in our part of the country. And and even in their series, if you look at, if you take out the loss to follow patients, the rest of the other immunosuppressants didn't do that badly also. So our of the 3 patients which we treated, 1 patient we treated with adalimumab. Luckily, that was during the peak of COVID. That is this patient. He didn't make it probably beyond a couple of months. We had an intestinal perforation and died. Because the other patient who was damn against starting etanercept because of the risk of tuberculosis, he was treated with the rituximab and he is on follow-up for the last 5.5, almost 6 years without any recurrence. He's on azathioprine follow-up for last 6 years. So he's doing well. So at that, I mean, just 1 patient. So, and unless you do a randomized control trial, you will not know which one works, because a lot of patients in a lot of series, if you look at it, a lot of patients are lost to follow-up, and we don't know what happened to those patients. Actually, they are doing well, or they had a complications and passed away or not. We don't know, and that is one thing to be noted down. And the rest of the things, I think.
So one question from an anonymous attendee asking, can henox-schonlein purpura be a differential in this case?
Yeah, just because it's a pretty long-standing history. It's not, it's a severe neurological involvement, central nervous system involvement, PNS involvement. I think, I mean, unequivocally, I mean, you can't blame the initial people whoever treated. He has seen all the major rheumatologists in this country. He was treated by, this patient was a very affluent businessman. So I don't know, almost every senior rheumatologist in the country, I mean, at least in Delhi, had seen him and treated him. So you can't blame them for treating it as pan, because he picked exact picture of clinical picture of a polyarthritis nodosa. He had every other feature. So in that way, I think pan comes as the first diagnosis, second diagnosis, and third diagnosis in this patient initially, if you didn't know about DADA2 as a first diagnosis in that. Yeah.
Okay. Thank you, Dr. Archana. Thank you, Dr. Vishnu.
Can I make a comment?
Yes,
comment?
sir. Yes, sir.
Yeah. So a very nice case, and actually, it throws up this, kind of very interesting concept that see, our knowledge is limited, and as the time passes, new discoveries and new, we discover new things, new syndromes, and the cases which were assigned in a particular group later on shift to the other group. So therefore, we should not be, that teaches us that we should not be dogmatic about our diagnosis unless we have a clinching evidence for that. So that is one part. But I think that, in terms of, for Ayush also, I mean, it should be more interactive. It should not be a one-way process, the entire presentation, right? So it should be more interactive. You could have made it more interactive, ask them questions, ask the attendees questions, so that you would get, much more involvement with that. And of course, in a young patient who presents with hypertension, with, vasculitic changes in the skin, and with testicular pain and fever, so obviously PAN would be the first diagnostic consideration. So therefore, I think that from that point of view, the novelty lies in a diagnosis which has been achieved by subsequent developments in immunology, especially. So I think, Ayush, you can structure these cases in such a way that there should be more scope for interaction. I mean, that is
definitely. I'll keep that in mind.
The other learning point, I think what's the thing is that, I mean, because this case was, I presented this in the Queen Square Gowers round. At that time, one of the major comments that we had was, I mean, everything is in the genes. So whether it is an acquired or acquired, I mean, whether unless and until he's a human being, the genes is the one which controls everything, whether the inflammation or the acquired or the any inflammation or a degeneration. Ultimately, it's happening in the genes. That was an interesting thing. And this case, I mean, it opens up of a lot of syndromes of autoinflammatory syndromes, because DADA2 is not the only autoinflammatory syndrome. There are a lot of autoinflammatory syndromes comes up, and it is a common pathway of a genetic condition and an acquired condition, inflammatory conditions. And we are looking into, coming to an age of gene therapies. This is another spectrum of so-called untreatable disorders becoming treatable disorders. Yeah.
Correct.
Yeah.
Thank you for that discussion. without further ado, we'll move on to the next case. And the title is as interesting as the case, and I'll hand it over to Dr. Chitrangada for the needful. Hey. Chitra. Slide.
Yes, sir. Sorry, sir. A very good afternoon, everyone. Am I audible?
Yeah.
Okay. So thank you to all the panelists and the participants for lending the precious time on a Sunday afternoon. I'll be presenting my case, the topic of which is too much positivity isn't always a good thing. So coming to the patient details, we had a 38-year-old female patient who presented with the chief complaints of intractable hiccups and vomiting. She had approximately 4 to 5 episodes per day since the past 2 months. It was associated with progressive left hemiparesis and headache, which lasted for approximately 1 week prior to the presentation. She had no history suggestive of any cranial nerve involvement, any history suggestive of seizures or myoclonus, tingling or numbness over any part of the body, any weight loss, fever, night sweats, alopecia, joint pain or rash. There was no vision loss or difficulty in seeing any part of the visual field, no history of abdominal pain, diarrhea. There was no bowel bladder involvement. Her past history, personal history and family history was not very contributory. She had taken Perinom and Domstal on OPD basis for the management of her vomiting. In her examination, her general physical examination was also not very contributory. In her central nervous system examination, in the cranial nerves, she had a right human palsy of the facial nerve of the and had mild spastic dysarthria. In the physical examination, she also had reduced tone on the left side of her body, and the power in the left upper and lower limbs was 2/5. There was areflexia on the left side, and her left plantar was mute. The right-sided examination was normal. So we considered the syndromic diagnosis as brainstem involvement with cranial nerve involvement and crossed hemiplegia. So common things common. So considering it's India, the first possibility that we had kept was infections, including TB, HIV, Lyme's, syphilis, and PML. CNS vasculitis, primary as well as secondary, both can have this similar sort of presentation. Secondary demyelination was probability more than primary demyelination. So we had also evaluated her for sarcoid and Wegener's. And in primary demyelination, MOG was a higher possibility as it can present as a stroke mimic more than NMO or MS. And the last possibility was a mitotic pathology in the form of low-grade glioma or an astrocytoma. Her routine investigation.
Just a sec. Before we move on to the investigation, so a patient presented to us with a area postrema kind of finding where the patient had intractable hiccups and vomiting, which is not responding to usually given over-the-counter drugs, as well as progressive hemiparesis. So those were the differentials considered. So anybody in the audience would like to pitch into amongst the differentials that were spoken about, which one you want to put your money on, or would you consider first, or anything like that before we move on to the actual findings? Okay. Yeah, please. I think we have one question. Dr. Srinivas says that he would like to consider NMOSD, but let's see. Go on, Dr. Chitrangada.
Okay. So the routine blood as well, that is CBC, RFT, LFT, were INR and APTT were normal. Moving on, coming to her imaging, in her MRI evaluation, so talking about the images from the left to right, the first image shows a sagittal T2 weighted image with a focal hyperintensity in the area prostrema. The second one is an axial T2 weighted image, which shows an ill-defined hyperintensity involving the medial temporal as well as the hippocampal head. The third, that is the C and D, are the diffusion and ADC weighted image. I'm so sorry. This is. So C and D are the diffusion and ADC weighted image showing a focal area of diffusion restriction involving the right optic tract and the ventral part of midbrain. The E image shows a punctate focus of enhancement in the medial temporal lobe. The F image is a coronal flare image showing hyperintensities involving the medial temporal lobe with the hippocampal head and also part of the posterior limb of internal capsule. G and H, so G is again an axial T2 weighted image at the level of basal ganglia It shows an hyperintensity at the level in the right putamen, the posterior limb of internal capsule, and also the periventricular gray matter. Sorry,
So-
periventricular white matter.
So, Chitra, rather than doing that, can you tell us what are the findings on imaging? Like on the basis of what you see, what are the two main takeaways from the imaging?
The first and most important one was the focal hyperintensity that we saw in area prostrema. Along with that, the hyperintensity is predominantly involving the temporal lobe, that is the medial temporal hippocampal head. And the third one was the diffusion restriction involving the optic tracts and the ventral part of midbrain. So these are the most important ones that we want to focus on.
Okay.
Moving on, her CSF examination showed 10 cells, all of which were lymphocytes. Her sugar was fairly normal with a level of 55 and RBS of 92. Her protein was slightly elevated considering the upper normal limit of 45. Her infective workup was negative. Malignant cytology was negative. In the immunological workup, ANA, ENA, and ACE levels were normal, and her viral markers were negative.
So we know that everybody wants to go for NMO testing immediately after this, but before we do that, is there anything else that is being considered by anybody in the audience? In the background of somebody, a young person having an area posthuma syndrome as well as a lesion involving the right temporal lobe?
I will come in between. You see that you have a syndrome, I mean, in a sense that you have a symptom complex which suggests to a localization, right?
Yes.
So you have area posthuma symptoms in terms of intractable hiccups, right? And then you have a focal neurological deficit, right?
Yes.
And so in the MRI, besides having the affliction of that area, you see the other areas also are getting affected in a larger manner. And there are large lesions, large, hyperintensities, which are, in areas involving various areas of the brain and the brainstem, right? So
yes,
you have to see from that point of view. You have to see from that context. Right?
Okay.
So anybody?
Would anybody want to comment on other possibilities?
One possibility being considered by the people in the audience is Neurobashia's disease.
Okay.
And MOG versus vasculitis is another one that's being considered.
So suppose Chitrangara, this imaging didn't show the the area prostrema that much involvement, but shows these large lesions elsewhere. So what would have been your radiological diagnosis?
So only on the basis of the lesions, then MOG would have been a higher possibility, because just MOG is basically a stroke mimicker. So considering that the patient had headache, we don't see headaches in.
Why do you say a stroke mimic? Because the patient did not have a sudden onset.
Sudden onset,
right?
but
so it was a progressive deficit for 7 days. It was not
it's not a stroke mimic, but this large blobby lesion, you are seeing. So what will be the term which we give normally?
ADEM, basically.
One is ADEM, but another would be a tumefactive kind of a demyelination.
Yes,
demyelination. So that is a broad group under which you will work, and you will try to narrow down your differentials.
Yes, sir.
So rather than going in the stroke pathway, you will go like that. Even after, these deficits were progressive, and you have this MRI where you have this widespread kind of thing. Okay.
Okay. Shall I move on?
Yeah.
As a lot of people had predicted, this patient underwent a cell-based assay, and the immunofluorescence was strongly positive, both for NMO as well as MOG, in the serum tested of the patient with transfected cell lines. Coming to the review of literature, I found one study which was conducted in 2020, which had a total sample size of 15,598. In this study, 10 patients tested positive for both. But if we compare the titer of NMO versus MOG, these patients had higher NMO titer as compared to MOG. Coming down to the prognosis, basically I found only one study, and that also considered only one neurological deficit in the form of optic neuritis. This study basically showed that out of the 23 patients that they studied, 6 were positive for both NMO as well as MOG, and these patients were treated with methylprednisolone followed by IVIG followed by rituximab, but they still had a poorer prognosis as compared to patients who were only NMO positive or only MOG positive. Now, as we all know, MOG basically affects the oligodendrocytes, and NMO is basically an affliction of the astrocytes. But sometimes the microglial cells, which act as APCs, they might cross present and can show reactivity to both MOG and aquaporin 4. That is the reason that some patients might test positive for both the antibodies. So our patient we treated with intravenous methylprednisolone. She received 1 gram daily for 5 days. This was followed by plasma exchange, and at the time of discharge, her power had improved to 3/5. Following this, we treated her with rituximab, the 02 protocol, followed by the 6 monthly follow-up. And the last that we evaluated her on OPD basis, her power was 4/5, and she was able to carry her activities of daily living without any support. So coming to the learning point, we can suspect a diagnosis on the basis of clinical and imaging findings where MOG is predominantly associated with tumefactive lesions and NMO is predominantly associated with area prostrema lesions.
Oh, I would beg to differ with you, and I would suggest that this is just an observational thing. And although the area prostrema lesion will obviously go more in favor of NMOSD, but MOG cases have also been described with area prostrema syndrome. There is nothing sacrosanct about it. And the secondly, about the tumefactive part, there's a wide, now the tumefactive demyelination is a wide differential diagnosis. Now this is a syndromic group rather than a distinct disease entity. You have to consider a lot of possibilities there in a tumefactive demyelination. So just by seeing a tumefactive demyelination, you cannot say that this is MOG, right? So MOG is one possibility. Occasionally, you know, the cerebral syndromes of NMOSD spectrum disorders, there is one group in which you will have a large lesions of the cerebral hemispheres in NMOSD also. So you cannot, but I think the main learning point from your this thing that you should send all the available antibodies for testing so that you can get this kind of a relationship, dual relationship, that there will be some cases where both will be positive. The more moot point would be that what is the percentage of these disorders, say in seronegative, when you are thinking as a NMOSD, but you do the test, you find negative, then what will be the percentage of MOG positivity in that?
Okay.
Can you just have a kind of a literature on that?
Yes.
Have you seen? Yeah.
So this study that I had quoted, let me just go back to my presentation. Yeah. So the study showing 6 out of 23 patients. In this study, so out of the 23 patients, 3 were positive for NMO and 2 were only NMO and 2 were positive only for MOG. So again, I think this study was also not very comprehensive because it compared only the optic neuritis part. But as we all know that it can have a lot of other manifestations as well. So per se, it is very difficult to comment upon the prognosis part of patients who are only NMO positive, only MOG positive, and patients who have both the positivities.
Yes, I agree with that. Right, we are in that stage of learning, I think, and we don't know yet that even for the primary disorder also, we do not have good data for prognostication. We have just some presumptive data. But I agree. But this is an interesting concept. Any questions Ayush you would like to take from the
so there are two questions.
Audience.
Yeah. So there are two questions. One is whether gliomatosis cerebri can be considered on the basis of the imaging that was shown. And another is that how can we consider tumor like dissemination like glioma based on the MRI? So both imaging based possibilities. Sir, I'll repeat the question. The question are that on the basis of the MRI, should we consider a disseminated glioma or a gliomatosis cerebri if we were only to see the MRI of this patient that was shown?
Yeah, but MRI is not to be seen only from radiological perspective. No, it has been seen in clinical context, and the clinical context has been a disease which is relatively acute in onset with recurrent vomiting, and then there's a progression of the deficits over a period of a week or so. So this is a relatively new onset and a reasonably acute onset. with some degree of development over a period of a week. So in that case, it is unlikely, though I have seen cases of tumors presenting very acutely also. Probably the earlier symptoms are not that significant, or the patient did not realize those symptoms and did not complain to the doctors. I think that the tumor, as I said, that when you consider a tumefactive demyelination, you have to consider all possibilities. You have to actually consider all the possibilities and narrow down your possibilities. So this is very easy to do. You can do the serology, and if you find that, it's very likely that the disease is a demyelination rather than a tumor lying at the back. So, and as I said, that the more you see with the imaging and with the advancement in imaging, the more varied pictures. So there is nothing absolutely sacrosanct about any of these diseases. You will see the same type of picture occurring in a mix of this patient. So do not get carried away by just seeing the MRI. See the clinical pictures, do the entire evaluation, and then go in for a differential and do the investigations accordingly. So they did a CSF study for malignant cells also, and that was negative.
Before we could be certain that it was dual positive, a repeat sample testing was also done. Both were done by cell-based assay. One was done at our center, one was sent to NIMHANS, and they showed concordant results. Only then did we come to the conclusion that it was a dual positive case. Another question has come as to how many seropositive MOGAD patients can present like NMOSD and vice versa. I think sir has already touched upon that. And
there are a few there are case reports, anecdotal case reports which have come in, but I don't remember reading a large case series from that context. But definitely, as you know, that the MOG initially was considered, it was not a new thing. It was earlier considered to be it was studied in the context of a marker for MS, but then that was given on, and only when the conformational changes by the cell-based assay became available, and that then the diagnostic yield improved, and then a lot of so-called seronegative NMOSDs actually came out to be MOG positive. So it's like that. But I think our knowledge about these disorders are evolving, and as exemplified in the previous case, we are much more to learn. So it's a relative thing, no? It's slightly more in this, slightly less in this, more commonly seen in this, and less commonly seen in this. But these are all relative, kind of judgments. So you can make a good assessment based on that, but you cannot be dogmatic about your diagnosis either clinically or then subsequently it needs to be proven by your serology.
Sir, thank you. Finally, before we close, I'd like to thank everybody who participated and sent in their cases. A request to keep up the enthusiastic participation and send as many cases as possible so that we have even more interesting ones in the next meeting that is there.
That's a very good initiative, Ayush. So I congratulate you and the entire young neurology forum of the country who are under the umbrella of IAN. And I think this should continue. You should actually kind of make it more interactive, and all these interesting cases will be helpful for all of us. Not only the youngsters, for all of us, it will be helpful and it will be a good learning experience.
Thank you, sir. Thank you for the encouraging words. And as always, the next meeting will be on the second Sunday of June, that is the 11th. So please make it convenient for all of you to attend, and we look forward for an enthusiastic participation. Everybody have a happy Sunday, and thank you.
Thank you.